Hi, everyone, and thanks for joining us today. We've got a great seminar for you today, and it's really an absolute pleasure to be hosting this. So thank you very much for the invitation. And also thank you very much to Dr. Bugeja from Ottawa and Dr. Seychelle Yohanna from Hamilton for joining us to share their important perspectives on this topic. So today we'll be talking about the expedited one-day living kidney donor evaluation in Ontario. And by way of introduction, my name is Sunita Singh. I am a transplant nephrologist and also a donor nephrologist here at the University Health Network in Toronto. I am also the medical director of the Living Kidney Donation Program here, and I currently hold the position of chair of the Living Donation Advisory Committee at Canadian Blood Services. So I'll be navigating you through this webinar. So just throughout the next hour, we'll be talking about several topics. The first is we'll be covering the Ottawa one-day living donor evaluation program pilot program that Dr. Bugeja will be covering. And then we'll also then be hearing from Dr. Yohanna about the Hamilton one-day program and other provincial initiatives. And then we'll be opening it up for questions and comments from the group. So please, throughout this presentation, feel free to include your questions or comments in the chat. I will be going through those during the Q&A session at the end. So please go ahead and share those, and I will be fielding those questions. So to start us off, I'd like to introduce our speakers. First, Dr. Bugeja is a nephrologist, and she's also the director of the Living Kidney Donation Program at the Ottawa Hospital. She was one of the winners of the 2021 pitch competition back in September 2 years ago as part of Living Donation Week, and her project really was focused on looking at this one-day evaluation for living kidney donors. So we're going to be hearing some of those preliminary results from Dr. Bugeja today. And we are also pleased to have Dr. Seychelle Yohanna joining us today as well. And Dr. Yohanna is a transplant nephrologist at St. Joseph's Healthcare in Hamilton, also has significant expertise in quality improvement, and she currently holds the role of provincial lead at the ORN. And so we're going to be hearing about important initiatives in Ontario, and the ORN, sorry, for those who are not in Ontario, is the Ontario Renal Network. So at this point in time, I'm going to turn it over to Anne. Thank you very much, Anne, for sharing your results with us over the next 20 minutes or so. Over to you.
Thank you very much for the invitation to join all of you for Living Donation Week. I'm really happy to be here and happy to talk about some of the work we've been doing. I'd like to just start by acknowledging the people around me who help make this work possible, including the Ottawa Hospital donor program, the coordinators, our clinical care leader, our donors, our donor candidates, everybody, and our surgeons. The Division of Nephrology at the Ottawa Hospital, who provides me with some time to do this sort of work. I'd like to acknowledge Dr. Yohanna and the St. Joseph's Healthcare Donor Program team, who helped us get our one-day evaluation off the ground. And this research is funded by our Ontario Health Research Initiative and funded by TAHAMO, and as Sunita mentioned, through the pitch competition, UHN and Jumeirah Transplant Center and the Canadian Society of Transplantation. So a lot of people to help. So to sort of set the stage before I dive into the one-day evaluation is, just as a review for all of us, is that the demand for kidney transplant really does exceed supply. So we need new ways to try to figure out how we're going to increase living donor transplant rates. And one of the issues is the living kidney donor evaluation process that has been reported by our donors to be difficult to navigate and often very long. And we know can be up to as much as 10 months in Canada. This lengthy donor evaluation process is associated with significant financial as well as emotional costs to donors who are just really desperately seeking to donate to their loved one. Not being able to do a living donor transplant in a timely fashion, not being able to donate when you would like, can result in reduced access to transplantation, which would mean for the recipient being on dialysis longer. And we know that dialysis is associated with less quality of life and less survival. And where this idea of the one-day donor assessment or one-day donor evaluation program initially came from was from a group in Ireland who published this almost 5 years ago now, where they were able to increase where they took the one-day donor evaluation and it helped increase their living donor kidney transplant rates from about 4 to 32 per million. And I've got some stats, thanks to Paul off to the side here, that in Northern Ireland in 2022, they're at about 22.6. And in Canada, we've been holding anywhere, well, around 11, 12, I would say generally around 12 for the last 12, 13 years or so. So when we thought about trying to implement this in our center, the first step was we had to look at our standard evaluation process. So, what are we doing and what do we need to do better? What can we do differently in order to set up doing most of this in one day? So at the Ottawa Hospital, this is a map, a process map of what our standard evaluation currently looks like, although with some modifications since we've introduced the one day. So like in other programs, someone has to call. We don't solicit for donations. So someone expresses an interest in becoming a kidney donor. Often a donor coordinator will briefly speak with someone over the phone just to answer any initial brief questions, initial brief screening. But this is all very brief, ideally to set up sending a questionnaire that involves asking about their health history, both medical and surgical, and their travel history. And then this gets reviewed. And sometimes there are obvious reasons why they cannot donate, and they'll be declined right from the bat. Or the coordinator may ask one of the nephrologists if there's any concerns right from the questionnaire. But otherwise, they enter something that we call phase one. And this is where they get more extensive education, and they do some preliminary investigations that then get reviewed by the nephrologist. And then if those initial investigations are deemed acceptable, let's say safe for the donor workup so far, then they move on to phase two, where they get a test in nuclear medicine, a CAT scan of their abdomen. They see a social worker. Then at some point they see a transplant surgeon. Then they see the nephrologist. And then after all of that, and we've had a chance to review the other imaging and consultations, then they're deemed as a candidate, or they're approved to donate. And so this will often involve multiple trips to the laboratory, either outside or of our hospital or at the hospital, and separate trips for some of these tests and consultations as well. Often the transplant surgeon and nephrologist are separate, for example. So then we took that, and speaking with the team at St. Joseph's Healthcare as well, is we came up with this process map for our one-day evaluation process. And so again, the donor will express an interest in donating. We will send them the health questionnaire and the consent form. And once we get a signed consent form and questionnaire, we move on to doing some preliminary laboratory investigations, and then discuss options for doing a standard donor evaluation or doing the one day. And then if they are agreeable to doing the one-day donor evaluation, they have a virtual visit back-to-back with a social worker and then a nursing education 1 week prior to doing the one-day evaluation. And so this is just an example of it's the same process map for 3 donors. Currently, we're able to do 3 donors per day in our center. And we do this 1 day per month. And they start early in the morning with nuclear medicine, which we use to measure their kidney function. And they often have to return to this department to have several blood draws. But they start there initially, go there to do a CAT scan of their abdomen to look at the anatomy, particularly for the kidneys and the vasculature to those kidneys. They go off to have an electrocardiogram, perhaps some cross-match blood work and a chest x-ray. And then in the afternoon, in the same clinic, they will see the transplant surgeon and then see us. And there's also the donor coordinator. So there's 3 of us at the clinic in the afternoon. And then we make a decision within 2 to 4 weeks as to whether or not they are acceptable candidates to donate. And this gives us some time to review final reports and discuss the candidates as a group and book any additional testing that may be required, although often not. So when we were implementing the one-day evaluation, we wanted to be able to study it, to really evaluate it and understand the good things, the bad things, what can we do to make it better, specifically to determine whether donor candidates and the stakeholders, i.e. the people who were involved in helping implement this, so the managers in the various hospital departments, the other participants in our donor program, like the surgeons, the administrative person, the nurse coordinators, would everyone find this expedited process to be acceptable? And then to identify factors that would influence its implementation in other centers. So I wanted to be able to provide actionable steps that could be transferable to most, if not all, transplant centers, regardless of healthcare system. So briefly, just on study design is with qualitative specialists, we created semi-structured interviews to explore the perspectives of the candidates who participated in this process, as well as the stakeholders who were instrumental in helping implement it. The donor candidates were interviewed within 4 weeks and often within 2 weeks of having completed the one-day evaluation, so that we did not have any bias towards what we would say confounding bias, but basically any bias around the actual surgery or their post-donation experience. We wanted to be very close to and focus on the evaluation itself. And ultimately, a priori, I had decided that we, based on some theory in the literature, that we would continue interviews until we could no longer identify more themes, until we weren't learning anything new. So we saturated pretty quickly with 13 stakeholders and 18 donor candidates, most of whom were women, and 39% of whom have donated a kidney, and some of whom are waiting in a kidney paired exchange program. And we conducted these interviews from June to December of 2022. So this is unpublished data. It's currently under review that I can share with you. And so there, again, there's a whole theoretical framework when we talk about interviewing anyone, in fact. But I'll start with just giving you what I think is most important is some of the take homes from our donor candidates. And for example, one quotation is, if you hurry up and do this, referring to the one-day evaluation for the donors, then they know if they can't, the recipients can then start to look at other options. So this really spoke to the issue that they appreciated having it finished as quickly as possible, so that, again, if they couldn't donate to their intended recipient, that they could look at potentially other donors or other options. From a work perspective, it was much easier to be able to take one full day off work than to take off time here and there, because I live quite far from the hospital. I would have had to take hours off every day just to go for one test. So again, particularly for those who live far from the transplant center, this was very conducive to saving a lot of travel and time. Although we did find that the one-day evaluation was extremely well received by everyone, regardless of where they lived, but does take care of this issue for those that live outside of our region. And then from the stakeholders, sorry, this one's a bit of a mouthful, but I think it captures a few different points. I think that the most important thing is patients getting through, working through the system as quickly and being able to navigate it as easily as possible. The ability to do all of this stuff in one day makes a lot of sense. Then people will be less concerned about going through the process and some of the financial hardship of having to miss multiple days of work to coordinate all these different appointments when not done on a one-day basis. So I'm presenting this quotation to illustrate a few different points. So one of the common themes that we found from the stakeholders is that everyone was very motivated to work together to provide not only the ability to be able to determine donor candidacy very quickly, but also to provide our donor candidates with the best experience possible. Recognizing that this largely involved a reallocation of resources. It didn't require new resources. Also with the idea that, sorry, I just blanked on what I was going to mention and keeping, I guess all to say that it's keeping everything very patient-centered. I think that the only downside we found was with our surgeons was that they were accustomed to being able to take donor candidates and sort of place them in any of their general urology clinics here and there. This sort of having the one-day evaluation forces them to have to spend a certain period of time, one day per month, to come and see these patients. So that was a bit of an adjustment, but they were all on board and willing to do it. And again, to keep everything patient-centered and to provide the best patient care that we can. And I think I have one more quotation. By establishing the one-day evaluation process, we made sure that we're not ordering tests that are no longer evidence-based or that there's no longer a requirement for. Not all patients need to do 24-hour urine collections, which is a time-consuming test for donors. This was a particular issue for my program with getting these done properly. I think just looking to improve our evaluation process overall, making sure that we're doing what we need to do, but not an excess of tests that maybe aren't necessary, help the program overall. So this did help streamline our overall donor evaluation process. Our standard evaluation process has become a lot faster as well. And our donor program seems to be functioning very well. We haven't had anyone turn down the one-day evaluation. Everyone has wanted to do it. It's just a matter of finding the spot, if not, say, within the next month, the following month. Is often the case. So I've just given sort of a broad level, high level overview of our results so far. So it's easily to say that the one-day evaluation has been deemed acceptable. It was overwhelmingly perceived as time and cost effective by our donor candidates. We do know that our donors are being approved earlier. I would add that one thing I also learned and that we're going to move forward with in our program is just providing a more global trajectory right off the bat, a little bit more clear to all of our donors, regardless of their evaluation process, would be helpful to know that they have to do those initial investigations as quickly as possible to get booked into the one day as quickly as possible. Our stakeholders recognize the need to adopt this collaborative approach, an evidence-based approach, putting the candidate first. That it really was just an issue of reallocating existing resources, not adding any additional time or cost beyond the initial implementation meetings. And that I didn't provide a quotation around this, but another theme that came out was that we need to prioritize the donor candidates with the transplant eligible recipients so that we're getting the recipients who are ready to go transplanted as quickly as possible. And I expect there may be some questions about that, and I'm happy to elaborate on that further. Some of the limitations of this work was that we didn't obtain perspectives from kidney transplant recipients who had donors go through the one-day evaluation, and I couldn't compare the standard evaluation directly against the one day. There could be unintended consequences. Specifically, these interviews have focused on this implementation phase. Now that we're going into maintenance, we're now almost 2 years out. It would be interesting to see if there have been some unintended consequences now that we've been beyond that initial phase. And of course, some longitudinal studies, ongoing longitudinal studies, ultimately looking at outcomes of the donors and recipients would be worthwhile, and ideally with more than one center as well. So the next steps is we have completed a full economic evaluation to assess the benefit, the net economic benefit from the one-day process. I don't have the data ready, didn't have the data ready to present that today, but I can say that we have shown that it is cost effective for both preemptive transplantation and as well as for patients who are on dialysis awaiting a living donor transplant. And we're just in the process of writing that up. Thank you.
Great. Thank you Thank you very much, Anne, for that presentation. There's already some questions coming through the chat, but we will save them for the end of the session. At this point, we will turn it over to Dr. Seychelle Yohanna. So as I mentioned to you before, she is Provincial Medical Lead for Transplant as part of the Ontario Renal Network. And we're looking forward to hearing from her, not only about her experience leading the one-day evaluation process at St. Joe's and Hamilton, but also the initiatives that are ongoing at a provincial level. So Seychelle, over to you.
Thanks, Dr. Singh, and thanks, Dr. Bugeja, for that great talk. To be honest with you, I don't have slides ready. I'm just going to talk from experience. So I'll first talk about the one-day donor clinic, which actually the thoughts or the ideas around improving the living donor evaluation started for us at St. Joe's Hamilton back in 2016. When I think about the living kidney donor evaluation, I kind of reflect and I think in any other area outside of healthcare, if you were in the business world or in any other type of industry where you were trying to make more people do something, you would you would really aim to make that experience be as efficient and seamless as possible. So we haven't exactly adopted that in healthcare, partially because of resources, but I really thought, like, how can we make this experience for living donors as really as painless as possible? Because I kind of put myself in their shoes and think, like, if I had to come to the hospital on average anywhere from 9 to 15 times, which is what we found in our audits, I would lose my mind. And there's actually probably very little chance that I could make it to the end of the evaluation, which again, on average, as Dr. Bugeja mentioned, is 10 months in Ontario. So we really thought about, like, how can we make this as good as possible for living donors? Not only because we want more people to donate, but we actually, like, these are altruistic people who are coming forward to do a very amazing thing for another individual. And so it really, they deserve a good experience. So it started in 2016. Similar to what Dr. Bugeja did, we really first looked at what we were doing in our program. And so we made several changes, adjustments, eliminations. We wanted to make the testing as the process for all candidates, not just the one-day donor candidates, as efficient as possible. And with my Choosing Wisely hat, we removed several tests that really were outdated and passed on from years ago. We made the process as sort of tight as we could. As opposed to Dr. Bugeja's program, we actually eliminated that telephone interview, and we put all of our healthcare, our healthcare questionnaire online, and that became the first interaction you would have. You had to submit that healthcare questionnaire on your website, on the website. And so once we were happy with the elements of the evaluation, we then sent out a survey to all of our living donors who had donated. In 2016, we sent this survey out. We sent probably about 40 or so donors returned the survey. And the survey asked questions about the living donor evaluation itself, not anything else, but just the evaluation itself. And we asked questions about the evaluation, and the survey was sent out 3 months after donation. And we received several amazing responses and lots of great quotes, similar to Dr. Bugeja, but lots of like, hurry up, why does this take so long? It's so frustrating. I found myself wondering, when will I donate? All of these difficult to read responses, but of course understandable given what they had gone through. So, that sort of added more fuel to the fire. So here we are, we're building a case locally for why do we need this clinic. So we already had baseline data to show patients were coming several times unnecessarily. We knew it took too long. Now we had qualitative feedback from donors to say, hey, like this has to change. And so that sort of started the series of meetings with all the stakeholders across the hospital that were probably in 2017, 2018, that eventually led to this really amazing collaboration that we started in March of 2019. And so our one-day donor clinic starts and ends very similarly to Dr. Bugeja's. And we evaluate 4 donors a day. We have been doing this now for 3-4 years. We have at least 150 or so donors who have gone through the clinic. The feedback from donors has been uniformly very positive. We have TAP ambassadors, so transplant ambassadors are peer support, who come to each and every clinic to provide peer support for donors who are going through the process. It's been celebrated at several of our hospital level committees and events, because it really highlights like a very strong collaboration, again, across multiple departments. And so, yeah, we've had a great experience. Everybody loves it. It's not easy all the time to coordinate. It's always juggling schedules and and whatnot, but we do it because it's a program priority. And I think we've all sort of seen the benefits to donors. You know, even if the recipient doesn't get a kidney faster, for the donors, they know their answer faster, which is so key for them in terms of their life planning and work planning. So that's the Hamilton One Day Clinic. We will be conducting an analysis of the One Day Clinic. We just received funding last year from the Kidney Foundation to do a larger study looking at process and outcome measures in patients who went through the One Day Donor Clinic and compared to historic and contemporary controls and controls across the province as well. So we're excited to embark upon that study to put some teeth into the argument that really every program should be doing this. Yeah, so that's our plan at St. Joe's, and I'm happy to answer any questions about that. I'll then just turn also to talk about the province and what we're doing to increase access to transplant. So back in 2017, two large provincial organizations ORN, the Ontario Renal Network, and Trillium Gift of Life, TGLN, who were historically sort of siloed, came together to say, to put their heads together to say, how can we increase access to transplant? And there became a new and very needed focus on transplantation and increasing transplantation in Ontario. So over the past 6 years, there have been major advancements in terms of the education that we deliver to staff, patients, and families. There have been there's a new transplant ambassador program. So if any of you don't know that, that's a patient-led program of peer support. And there are several hundred ambassadors who have had several thousands of interactions with patients and potential donors and caregivers. And they really provide that lived experience that prior to this was really not ubiquitous across all programs, but now all 27 regional renal programs have options for peer support for their patients. And then there's a new and sort of renewed focus on transplant specific data. So programs are receiving their transplant specific data on a regular basis for them to understand where are they at in terms of several process and outcome measures. So for example, referrals and number of transplants and number of living donor transplants and preemptive transplants. So they're routinely receiving that audit and feedback data, which is sort of helping to drive improvement and increase transparency as well. And so that's just, the tip of the iceberg in terms of what's going on. There's a huge collaborative now. All 27 renal programs get together every couple of months to talk about experiences and share best practices. Each of the renal programs has a quality improvement team dedicated to increasing access to transplant. And everybody's sort of like, they've taken it on now at the renal programs as it's their thing. Whereas I think historically that it may have been something that lied more with the transplant center. I think now the renal programs are really jazzed about transplant, and they're really finding innovative ways to try and make the process, at least the early part of the process that's under their control, as seamless as possible. So yeah, that's kind of what's happening in the province. In terms of living donation, there is also a new living donor working group, which is the first ever that, again, ORN TGLN has facilitated. So all the leads of the living donor programs are going to come together and kind of put our heads together and think about how can we take the One Day Donor Clinic and spread it broadly. How can we learn from each other in other areas of the evaluation or living donation? And how can we sort of drive forward what everybody here wants? We all want to see more patients receive a living donor transplant. So that's what's going on. I'm happy to also take questions. I know Sunita has some. There's lots in the audience as well.
Thank you very much, Dr. Yohanna. So great perspectives from both Dr. Bugeja and Dr. Yohanna. So I'm going to just open it up now for a panel discussion. Lots of great questions coming through. So I'll just start actually with a great question from Oleg. And I'll read it out to the two of you and kind of expand on it. Any problems with donor workup not being aligned with the recipient workup? So, this is a really important point. We know that the whole purpose, of course, of getting donors to a decision faster is, of course, the patient experience, but ultimately the goal here is to get to transplant. And we obviously know we need a cleared transplant recipient to make this happen. And of course, we also know that our transplant recipients typically have a more complex and a more, typically involved workup. So, from an alignment perspective, you both of you spoke specifically about the donation program, and I realize that not necessarily both of you hold leadership roles on the recipient side, but maybe I'll start with you, Anne. How did you handle that issue of trying to get things aligned? Because in our program, just to speak on our side, we typically, the donor is cleared before the recipient. So, but I realize not all programs may be the same way. So how did you handle that? And was that something that was part of the pilot program?
Well, I think we can expect donors at times to be cleared before recipients, certainly. But if you're dealing with a limited number of one-day spots, and depending on your volumes at any given time, right, you can have a variable number of donor candidates across any given year. So if you have to make decisions about how to use those spots, we felt it was important to look at the eligibility of the recipient. So in our program, we don't initiate donor workups unless the recipient has been referred for transplantation. I will just say that first. And then secondly, we would coordinate with the recipient team to look at where the recipient was in their evaluation process to make those decisions. An additional point I'll make to that is that we do have evidence that evaluating multiple donor candidates simultaneously can be cost effective from the point of view of recipients and the need for dialysis. So there are times that if we're trying to even get a preemptive transplant done for a patient that's really nearing dialysis, we've even worked at multiple donors for the same recipient in a one-day evaluation clinic.
Thanks so much, Anne. Seychelle, how about you on your end? And specifically, since you've been doing this, I think you mentioned 2016. So now we're kind of already at several years in. Did you ever get to a point or an issue in your program where you would have a donor cleared, the recipient would be potentially out of sync, and you needed to update or kind of renew the donor evaluation for it to be, to remain active? Because that's one of the things that we want to make sure that we align things well and that we can get to transplant without having too much of a lag, right? Because that is one of the potentially unintended consequences, that you have to obviously renew things as they become expired, especially since we all operate with standard operating procedures in our program. So maybe Seychelle, I'll turn that over to you.
Thanks, Sunita. It's not perfect. Because as we all know, issues with recipients and donors come up all the time. But I will say that we've learned over time, initially it was, hey, anybody can come in the one-day donor clinic. Then it was like, wait a second, the recipient should at least be referred. So as Anne mentioned, we do require the recipient referral to be completed. But then even then after that, we learned from even more. So, okay, the recipient's referred, but if their eGFR is 20, I don't need to hurry up with their donor. So that living donor, if they wanted the one-day clinic, we would put them on hold. We would say, like, you can have the one-day clinic when your recipient's GFR is more closer to 15.
Right.
So there is a lot of back and forth, and it is iterative. You do have to learn and adjust and learn and adjust. So, that's one example. But I also agree with Anne, who's stated oftentimes you have to work up several donors in order to get to the one that eventually does donate. So sometimes, like, even though your recipient evaluation takes long, your donor, you're going through donors, so you don't end up being super unaligned. But you're right, it's not perfect. And that's why, sometimes what we do is we say, okay, if we have 5 donors for one person, then, maybe we do it in a stepwise fashion. And some of them do it in the conventional way. not everybody's going to do the one-day clinic. And actually, as opposed to what Anne was reporting, we do have some patients who say, you know what, I don't actually want to do it in one day. I want to take my time. You know, which is totally fine. And so we don't have everyone who jumps on board. There are some who'd like to take it slower.
Thanks so much, Seychelle. And I think both of you have addressed really Heather's question here in the chat, where she was asking, does the donor workup happen after the recipient is added to the transplant list? So, you know, I think the vast majority of programs, based on your experience and also in ours, you know, donor evaluations, you don't necessarily have to be cleared and kind of listable. I think all of us are kind of starting our evaluations, and including in the one-day evaluation process, when at least somebody has been referred. So not necessarily clearable, and that certainly helps with kind of alignment, because then you would be potentially out of step if your recipient was cleared.
Well, and I think also, you know, I spoke briefly to the fact that going through the implementation of a one-day evaluation helped us make our standard evaluation more efficient. And because we've built this collaboration, you know, with other stakeholders within the hospital, is we've been able to, you know, leverage that to make our standard evaluation process faster. And we have our standard evaluation process in several cases, even down to 2 months.
Wonderful. Thanks, Anne. And I think, speaking of time frame, so can I just ask, generally speaking, so you showed your process map. So obviously before that one-day evaluation, there was there's clearly some preliminary blood work that needs to be done. So I saw on your graph, initially there's some preliminary blood work done. They come in for the one-day evaluation. Then there's a 2 to 4 week period of decision making. So if you were to take the whole process at your program, you know, where you include that, you know, contact, preliminary testing, acknowledging that people complete preliminary testing on their own time. And so some people do it faster than others, but just ballpark averages. If you were to include that time period, the one-day evaluation plus the decision point, what would your total time from like beginning to end generally be? And how does that compare to where you started from, like in your typical average evaluation? And what's the delta there? Ballpark, generally speaking.
Yeah, I'd have to give sort of a ballpark for that right now. But from the time that we receive a signed consent and questionnaire, so that we can actually start the labs and move forward, from the time that we start that to the time that they get approved, is usually not shorter than 2 months. So I would say 2 to 3 months with the one-day evaluation. Compared to 4 to 5 months and upwards. These are ballparks, because we do know that we have donors that kind of need to start and stop depending on other life events or their work or travel or whatever it is. So I'm not speaking about, and then we do have some, of course, some donors that are going to be more complex and require additional testing. But I would say that we've probably on average shortened it by about 3 months. But again, I think the bigger take-home point is we've been able to shorten both because of the collaboration that we now have. And any additional testing that we perform is usually from the cardiac point of view. We don't mandate cardiac testing for donors in our program, regardless of age. So there are times where at the one-day evaluation, we need to order additional cardiac testing, but we can usually get that within 1 to 2 weeks if they live within the region. Can sometimes be a bit more complex if they live outside the region.
Right. Thanks, Anne. Seychelle, I wanted to ask you, you know, you've been doing this now for some time. Have you noticed, when you look at your transplant rates, kind of what has, granted there was a pandemic in the middle of it, so maybe this is not going to be a super accurate way to look at numbers, but what has generally happened to your transplant rates over time? Because I'm just thinking of the article that Anne presented early on in her presentation. You know, Ireland started, however, from a different point, right? They started at a much lower donor rate. And so, of course, they had this big increase after the one-day evaluation. So they were starting from a different point than Ontario. But I'm just wondering if you can comment, you know, over the past 6 years, kind of what 6 or 7 years, acknowledging there was a pandemic, what kind of impacts you've seen in terms of your donor rates or even your preemptive rates, for example.
So thanks, Sunita. Well, there was a pandemic. So we were on a rise, then we weren't. Now we're back on a bit of a rise. The proportion of preemptive transplants has sort of stayed stable. Another measure that has sort of improved is transplantation, you know, with less than 1 year of dialysis. So sometimes if you can't achieve a preemptive transplant, the next best thing is a shortened dialysis time. So what we can see is the median number of days on dialysis is for the recipients, if they weren't preemptive, has come down. So that's good.
Yeah.
But I guess the full analysis will be coming. But the other thing to say is that our baseline rate was somewhere around 10 months. Like, I think that was the median. We were very much in line with the Emmett Garg publication that showed the median was 10 months in Ontario and Australia. So we did a baseline assessment. It was 10 months. I also suspect it's shorter in both cases, whether you're in the one-day donor clinic or usual care. But can't say for sure just yet. With our one-day donor clinic, because the time starts when you submit the health care questionnaire, if you're not going to proceed with the assessment in the next few months, or let's say we put you on hold, the time still starts, right?
Mm-hmm.
So you may have someone take 6 months, even though their actual evaluation may not have taken that long, but their time from start to end actually does take to 6 or 8 months or 9 months.
Right.
Because we may say, actually, you submitted your healthcare questionnaire, but not yet. We're not going to start you yet. So, but it'll still appear that it's like 6 or 9 months.
Right.
So,
okay. Perfect. Thank you very much. A great question here by Jody. And actually, Jody, I wanted to ask this myself. I think this is important when other programs are looking at this. What is your criteria or pre-testing done to get offered a one-day workup? I think that's important. Of course, both of you mentioned kind of limited spots per month. And we also know, and I think all of us are experiencing this, that the donor candidate population is changing. So we are seeing, at least my sense is that we're seeing more donors that are coming in with comorbidities on their questionnaire, more donors that are coming with metabolic syndrome or kind of issues that are where they might require some lifestyle modifications, weight loss, for example, before becoming a candidate. So, there's different types of donor candidates. And not everybody is kind of eligible right off the bat. And so Jody is asking here, what's your criteria for pre-testing? What's your criteria for getting in, or pre-testing that you need to have done to get into the program? And then as a follow-up to that, question is, what do you do when you incidentally detect things through the evaluation, right? So imaging, for example, a liver lesion or metabolic syndrome or prediabetes, how do you handle those abnormalities when you detect them? They're not an absolute contraindication, but they certainly may require some additional consultation, testing, lifestyle modification. So maybe I'll start with you, Anne, if you can tackle the criteria that you used in your program.
So we're trying our best to keep any selection bias minimal, because I think that's one overarching issue when we do examine various outcomes, is there's going to be a selection bias that we're not going to be able to completely get around. And we want to give, more importantly, every donor candidate an opportunity. So we're using the same preliminary lab tests as we do in our standard evaluation, which would involve a creatinine and looking at estimated GFR, as well as just CBC, electrolytes, urinalysis, urine albumin to creatinine ratio, just standard laboratory testing. And we don't have set criteria. The issue is just if there's any concern identified, then it needs to be reviewed by the nephrologist, who may decline right off the bat, or may say, oh, look, there may be an issue with their fasting glucose. They'll need an OGTT, an oral glucose tolerance test, pardon me. But we can move on with the workup and get that get that done. We don't necessarily, have to do that in advance. Similarly, you mentioned an example of more complex donors, like say someone who is living with obesity, for example. Again, we tend to be a little bit more perhaps liberal in our center, but we may be able to let them move forward and have those discussions as we move through the process, even an expedited one. And then other than that, it's really patient choice. Like, we don't do a full interview up front, but it's just giving them the option. Our coordinators will give them the option of doing a one-day or a standard evaluation when we're giving them the initial investigations, the recs for that.
Thanks, Anne. And Seychelle, how about in your center?
Yeah, so similar. They have to do blood work, like the routine standard blood work. It all has to be sort of reviewed and essentially normal. If there are any glaring abnormalities, like what you'd mentioned, metabolic syndrome, elevated GGTs or LFTs, we may say, okay, this may be not someone who should go into the one-day assessment. The other thing, as we review the healthcare questionnaire quite like in detail and make sure that, you know, if there are any red flags, if someone's BMI is close to 35, we actually ask them to lose weight in advance, and then they can enter the one-day clinic eventually once they are at an acceptable BMI, and then or we just start them in the regular way, and then over time they can work on losing weight. But it's a limited healthcare resource, so we do have to be considerate and think about what how can we best utilize it. And maybe it's selection bias, but I would argue that it's not really selection bias, it's real world utilization of a scarce resource. We don't have, it's only about 25% of our donors can each month can actually have this experience. So it's a scarce resource, and until we have more of it, we have to be a little bit, I guess, have criteria.
Right. Absolutely. I just want to read a couple of comments as well as a question. So this is a comment from Sean, or question and comment from Sean Delaney. So is HLA/cross matching done in advance of offering the one-day evaluation or afterwards? So I know KPD removes some barriers to incompatible donors, but knowing you are or aren't compatible to your intended recipient is a factor that some have to get their heads around. And that's a really important point, Sean, that you bring up, is the issue, of course, of knowing whether you're eligible for direct donation or not. So maybe I'll ask Seychelle how you handle this, the cross match issue, where you have it in your process.
So we actually draw the HLA blood work during the one-day clinic. So we don't actually have the cross match done. All the donors are told that you may not be a match, but we have KPD, and we really push and we really try to encourage patients to enter KPD because we believe in that program. And so we kind of, and actually, to be honest with you, the overwhelming majority of potential donors would enter KPD. So we don't actually want to waste time with a cross match prior to the one-day clinic. So, but we draw the HLA blood work during their nuclear GFR.
Okay, excellent. And here's a question from Heather. So maybe Anne, I'll ask you. Curious to know what the dropout rate is for donors who learn they aren't a match for their intended recipient, even if they could move forward through KPD. So we know that that happens occasionally through the the regular stream, for example. But Anne, in your one-day evaluation program where this has happened, because inevitably I'm sure it has happened that somebody has had a positive cross match, do you have? I know you don't have probably the exact numbers, but do you have a sense of whether that dropout rate was high or if generally it was pretty acceptable?
So far, we haven't had anybody. I think we may have had one dropout. We've had people go into KPD for sure. And we've had the situation, again, I mentioned that we do evaluate multiple donor candidates for the same recipient. So we just may have had a different donor go ahead.
Okay. And can I just ask also too, when it comes to donors and the one-day evaluation. So part of it, of course, is determining suitability, but a big part, of course, of the consultations is to be able to get an assessment of risk and a discussion of those risks, right? We all know that's part of the donor evaluation. And since, all of the healthcare provider assessments are all done in one day, do you ever find, or have you had any donors kind of tell you information overload in one day, as opposed to kind of having it, slowly over time kind of shared with you? Granted, too long or too slow may not be ideal, but sometimes, if someone is there all day, by the end, they may not be kind of necessarily absorbing all of the information, especially since, of course, risk discussion is such a huge part of what we do. So maybe I'll start with you, Anne, if you want to just share your comments, and Seychelle, I'd be interested to hear your thoughts as well.
So that's why we have the nurse education visit and the social worker for a total of approximately 2 hours. I mean, it could be less than that for several donor candidates, but like I would say, there's an hour set aside for the social worker, an hour set aside for the nursing education center. session, both done virtually a week before. And part of the feedback from the interviews has been that that's well appreciated. And part of the reason we also think that the standard evaluation process needs to continue is not only like there was also recognition that some may want to have a longer contemplation phase. So the one day isn't for everybody, even though we haven't had anyone decline doing it, but we recognize that it's not necessarily for everyone.
Right. Seychelle, how about you?
Well, as I mentioned, we have had people decline the one-day evaluation. So I think that sort of in and of itself, weeds out a certain number of people who actually already know in advance they want to go slowly.
Yep.
And then from those who actually go through the evaluation, we do have people withdraw after completing the evaluation. But we don't know whether it's because of the question of HLA incompatibility or other reasons. But I think now I'm like forgetting the question that you're asking. What did you ask about again?
Yeah, so we were talking about the issue here is we were talking about the one-day evaluation, the information overload.
Oh yeah. So they sorry. So we also have a social work visit done virtually at a separate time, so that helps. And then they're constantly emailing and calling each other between the donor candidates and the coordinators. So they have lots of opportunity to ask questions at a later time.
Mm-hmm.
And we always make sure we tell them like umpteen times that that they can take their time. Even though they went through the one-day evaluation, they can still take their time, and they have access to email and calling our coordinators, and I always tell them if they want an additional visit with one of us, we're happy to have that.
Wonderful. I want to read a comment here from Sean, congratulating you both. This is fantastic work, especially from the perspective of having a number of potential living donors come forward to try to donate to me. Workups range from 3 to 20 months. It's quite the range. And folks directly associated with me for a variety of reasons, but frustration with the process and delays was by far the most common concern. Congratulations on the success of both your programs. Is there a plan to actively promote the one-day success through the CST, to the CBS LDAC committee, or other venues where other provinces or programs can benefit from your experience? So maybe, Seychelle, do you want to speak to this? And I can also chime in as the chair of LDAC.
Yeah, I presented about it at last year's CST. This year I won't be going because I'm on maternity leave, but maybe Anne will. But definitely, I think Anne already has a publication in process. I also have a publication submitted, so hopefully, in terms of knowledge translation, we'll be sort of getting the word out. And like I said, we did a talk last year at CST, hoping to continue touting the horn of this amazing patient-centered initiative.
And I think at the in terms of spreading the word, as you say, the more kind of data that comes out, particularly I'm very interested, and you mentioned the economic analysis, that would be really, really important. As more and more data comes out, of course, it's helpful to try to spread that message. So certainly something that will be really valuable, and these projects that you guys have both led are going to be really important. I think we'll have time for one more donor. So one more question, sorry. So I'll just end with this one. And both of the questions that remain have to do with multiple donors. So if multiple donors are worked up, it's plausible that at the end that they all can end up going through is it possible that they can all end up going through the one-day workup and then after decide which one would be moving forward to donation? So that's kind of an issue. It's almost a simultaneous one-day workup evaluation. So there's that question. And then the last question to that is for those who are worked up and don't end up donating. So if you have 2 approved candidates, are those people generally told about non-directed donation? I think that's generally what most programs do, and I think I see Anne shaking her head. But I would be interested in this final minute if you guys can comment on what happens if you have, or is it possible to have a simultaneous one-day evaluation for donors, and if both are cleared, how do you guys work through that? Maybe Anne, I'll turn it over to you for the final word.
We'll work up simultaneous donors in a one-day clinic, and then it's a clinical judgment call on who will proceed if we have those multiple donors all accepted.
Excellent. Thank you, Anne, for that response. And I want to take a moment to thank, first of all of the attendees who joined us today. Thank you very much for being with us and for your engagement and your wonderful questions. I want to thank Dr. Bugeja and Dr. Yohanna for just presenting their excellent work and for kind of participating in this great session. And a huge thank you, of course, to our sponsors. I want to recognize specifically our wonderful sponsors, the UHN Foundation, Astellas, who's been a great partner to the Center for Living Organ Donation from the very beginning, and of course the Kearney and Cahill families who have been just such wonderful supporters of the program. And thank you very much for everybody at the center for hosting this webinar and all your work behind the scenes to make it happen. Thank you very much for joining us. Have a great day.